Okay. Good evening, everyone. My name is Lauren Gueits. I'm the host of tonight's Airway Health Solutions conversation. We're excited to kick off 2021 with Dr. Ben Miraglia. Welcome back. Happy New Year. Nice to see you.
Happy New Year. Welcome, everybody.
Thank you.
Looking forward to it.
We have a hot topic tonight. We had so much interest. We had over 200 doctors registered, and a lot of the doctors were actually mentioned that they have TMD themselves. So we're excited to really kind of tackle this topic in perhaps a different light, bringing expansion into the mix and having a lively Q&A after. So if you were not able to leave a question and you do want to ask a question, please feel free to use the chat box, or for everyone on Facebook, kindly leave a comment and we'll try to get everyone's questions answered tonight. Okay, so let's kick this off, and let's start, Dr. Miraglia, by just why don't you tell us about your evolution, maybe an overview of how you treat your TMD patients, because I'm sure it wasn't what you learned when you first came out of school.
Yeah, definitely. And so graduated University of Buffalo in 1993, and so starting to get painful to say that date now, but in 1993, left dental school, get into a residency, join a private practice, and begin. And, you know, for the first decade of private practice, it was crown and bridge and reconstructive dentistry and mostly fixed, which was wonderful. And then you have, of course, you have your population of patients that might have some TMD symptoms. And in the mild category to moderate category, I was addressing that in my first decade of kind of treating patients. From 1994 to about 2004, I was making the splints, night guards, orthotic, all of the different words that were used to describe, what you could do to help someone with TMD symptoms. And in the mild to moderate category, we were having reasonable success. In the severe category, we were referring out to offices where they were more capable and able to handle the severe conditions, disc displacements, locked jaw positions, patients who were really struggling with higher levels of pain and discomfort. We were sending those out, and we developed, very nice referrals and relationships with people. Like in my backyard, I have Dr. Gelb to refer to. So Dr. Michael Gelb has done a wonderful job treating patients that we've referred to him over the years, and providing a lot of comfort and a lot of relief to patients in severe categories. So I had that kind of covered, so to speak. TMD was covered. If it was mild to moderate, I could do a splinter, a night guard, and then of course I could refer to Dr. Gelb if I had someone severe. And then, 10 years goes by and it's 2004, and you start to take clear aligner courses and other orthodontic courses, and then orthopedic courses and growth and development courses. And next thing you know, you're learning a lot more about growth, development, etc. As time's going by, you're starting to treat your patients, and one thing leads to another. And over the course of time from 2004 to today, which that's a long span, that's 16, 17 years, we began in the mildest of categories. But as we noticed, we were treating patients with expansion, and the priority was developing the upper jaw and upper tooth position so that the mandible could have some freedom. We start to recognize that the symptoms are fading away. And just like anything else in dentistry, where you start out in the mild category, and then as you get more comfortable, you start doing more and more and more challenging type of cases, or more and more, complicated type of cases. Well, it's the same thing in the TMD category, and a real slow progression over time, where now I'm very comfortable treating TMD symptoms in the most severe list of, symptoms with expansive and or growth and development orthodontic and orthopedic techniques. So basically like an evolution, because you're thinking about over a long period of time, the changes were kind of slow and gradual, and we evolved to a point where in the mild to moderate category, we can jump right into orthopedic and orthodontic therapy. And now we're developing a position where everything is happy. We've got the good occlusion, we have a happy condyle, we have an appropriate disc placement, we've got happy musculature, and we've got a really totally asymptomatic patient. But when it gets to the severe category, I still might make the referral to Dr. Gelb-like office, where he can take that patient from severe to mild in a short order, and then I could have them back. So it becomes a collaborative effort. And in the severe category, where there might be disc displacement, or there might be a pain level that is too much to begin orthopedic and orthodontic care, or the patient might have limitations in jaw movement and mobility, we would have them work with him first and then go and graduate from basically his program of getting them from severe to mild. I could get them back and, do the necessary orthopedic and orthodontic treatment. So we have this certain path of evolution, which takes us from, okay, in 1994, I was making night guards and splints. Mm-hmm. Today, I don't make any of those. So I don't make a night guard or a splint. And that I look at that patient differently. If they have a malocclusion, then there's a percentage of them that have TMD that goes along with that. And TMD becomes a symptom of the malocclusion, and we treat that patient as being underdeveloped. So our diagnosis becomes, we have someone who's underdeveloped in their malocclusion, and we're looking to develop them to a point where not only do we have the right occlusion, but we have a position where the muscles are correct, the disc is correct, the condyle is correct. Basically, everything lands where it belongs. And next thing you know, you've got a patient who has a very healthy occlusion, a beautiful smile, but also is asymptomatic. And whether it's mild to severe, those symptoms all fade away. So we basically treat the TMD patient with growth and development. That's where we are today.
Wonderful. And we have a case to show just that in just a moment. But before we do that, let's kind of connect the dots with some of the science and the research. I'm just going to go ahead and share my screen for a moment so we can kind of go over the cases, but then also talk a little bit about Dr. Gerald Simmons and how we are excited because he's going to be joining us on February 10th, and you're going to have the pleasure of interviewing him. I know you're, we're all big fans of him, but I know you're going to pick his brain so well.
Yeah.
Tell us a little bit about what you know about Dr. Simmons that you thought he would be such a terrific guest on our program, which I'm looking forward to as well.
Yeah, he is just fabulous. So he's one of my favorite people, and I probably met him about 6 or 7 years ago and got introduced to the research that is kind of related to TMD, bruxism, sleep disorder breathing, malocclusion. All of these things are comorbid. And since we have all of these things wrapped up in multiple patients, the meeting him was really eye-opening for me. So the short story is Dr. Simmons is triple board certified in neurology, sleep medicine, and epilepsy. He has and is still doing research, but has spent decades doing research in the sleep disorder breathing category. And the idea is a lot of it was at Stanford with Dr. Christian Guilleminault, who a lot of people know. If you're getting involved with sleep disorder breathing and OSA, you're probably going to come across Dr. Christian Guilleminault's name. And next thing you know, you recognize that Dr. Simmons was doing a couple of decades of research there at the same time at Stanford. Well, we're in luck because we're going to be able to host him next month and really pick his brain for an hour, like you said. And an hour isn't enough for this gentleman and the research. Now, the research is partly his and others as well. But the short story is written in this sentence here, which is kind of like a culmination of what he understands now, that nocturnal bruxism is a compensatory mechanism of the upper airway to help overcome upper airway obstruction by activation of the clenching muscles, which results in bringing the mandible and therefore the tongue forward. The study suggests that such a compensatory mechanism is the etiological force behind nocturnal bruxism in many patients. And what we start to recognize is that our patients who have those crowded deep bite malocclusions, most of them fall in the category of clenching, grinding, and or sleep disorder breathing. So because all these things are woven together, we meet someone like Dr. Simmons and we recognize that what he's describing is an airway protection mechanism. And that is now the missing link between nocturnal bruxism and OSA. And then, of course, nocturnal bruxism as a protective mechanism against OSA during sleep, neurology of sleep and sleep-related breathing disorders and their relationship to sleep bruxism, the occurrence of sleep disorder breathing in patients with TMD. So the comorbidities of having sleep disorder breathing and or all the way to OSA as the worst category is that you have patients where they have a malocclusion of some sort. Then they have symptoms, and the symptoms of TMD and or bruxism or clenching and grinding are all wound together and related in that they all stem from being underdeveloped. And if the jaws are underdeveloped, we have a lot of issues where our patients have opportunities to be in these categories. And so migraine, obesity, sleep bruxism, malocclusion, TMD, when you have someone who has underdeveloped jaws, they have the opportunity to touch any or all of these things. And so the more patients you see, the more you recognize that You have patients in the mild, moderate, and severe category. And you do have patients where they might experience one or two of these symptoms. But then the more that you're paying attention to these things, the more you recognize, hey, my patients with the underdeveloped jaws, well, I'm recognizing more and more have a sleep bruxism issue and or a headache issue and or a TMD issue and or struggle with overweight or obesity. And then you start looking at this list and you recognize these symptoms are more common than not. So then you start realizing, again, the more you're looking, the more you see that the patients experience multiple symptoms, not really just one. So we kind of stopped treating the individual categories. In other words, I'm not just treating one item or the other. Now we're treating the patient. And so treating the patient and trying to get to the bottom of it all means developing the jaw and the teeth in a position where you have enough room for the tongue. And so with Dr. Simmons' help, I was able to understand that the reason the lower jaw is moving at night is because there's airway resistance, and the nasal airflow resistance is where it builds. So when you have an airflow resistance issue, all of a sudden you're going to have the opportunity to trigger basically sympathetically driven jaw movement. And so lucky for us, we get to spend an entire hour with Dr. Simmons on his and others' research that show what happens to a patient when they fall asleep and then the air isn't flowing well through the nose. Because once the airflow resistance starts increasing, it triggers this mechanism that leads to jaw movement to relieve that airflow obstruction issue. And so he is absolutely fabulous, and I try to see him speak every year, and I'm so excited that we're going to have him next month. So I believe it's February 10th, but you're going to clear that up.
Yep, mark your calendars.
Yeah, February,
I'll send
February
out a
10th.
reminder.
That is going to be really special. So he has helped change the way in which I look at patients and treat them, and he's one of the main reasons why I don't make a night guard anymore. Because if someone's jaw is moving and they can show me, if I can see signs of clenching and grinding, now I'm looking to develop room. And one of those main reasons is because of the space for the tongue. And if the tongue doesn't have enough room, it could only be back and in the way. If you give the tongue more room, all of a sudden, it can affect how well you breathe. And we have a nice example of our patient we're going to walk through that shows exactly that. Giving the tongue more room makes a difference.
We are. And, it's amazing the opportunity we have, because think about all the patients we have in a GP's practice that are in night guards. They're all clear aligner cases, right? It's amazing how you can have a hot list per se and kind of transfer all of them to aligner cases, and then you'll be really addressing the root cause.
The opportunity is pretty big because we recognize that we have a list of patients already in night guards and or splints. We also have a list of patients that we could be recommending night guards and splints to. The clenching and grinding, bruxing, all those words we use, those are so easy to find. Most patients have some sort of clenching or grinding issue, so you have an opportunity there. And then the idea is you could be working on, if you're working on so-called symptom list, then a night guard would apply, because you would work on treating the symptom by making a night guard and get it between the teeth. And it does prevent the teeth from getting together, so you can reduce the enamel wear. But the idea is the night guard's going to take the beating. The reason the night guard is taking the beating and getting worn out over time is because the jaw is still moving. So it's uncommon for a night guard to improve the airflow so that the jaw would stop moving. Whereas if you give the tongue a lot of room, now when the tongue has more room, it parks itself further forward in that space you gave it. Next thing you know, the jaw slows down its movement, or it gets eliminated altogether and the patient doesn't do any clenching and grinding.
Well, let's bring this to life and review this case. Okay, so tell us a little bit about this patient.
Oh yeah, so very nice lady that we meet. And at the time that we meet her, we do learn of an entire history in TMD. And so, she has, of course, from the smile line, we would recognize narrow, because the more we're looking for that crowded malocclusion, the more you start recognizing that's a deficient smile line. And so, you can see the crowding from here, but we're going to get into the photos a little further. But the idea is you have that open buccal corridor. So you have a narrow arch, and this patient has the right lip line. But when the teeth are collapsed in that far, what you want to start thinking about is how much room does the tongue really have? Because while you're looking at some front teeth, you really only see a canine to canine smile. So if everybody's going straight back from the canine, that tongue has a very limited amount of space. So what you want to do is pretend you're looking at this from the back of the head forward to see what kind of chamber is that tongue parked in. Is it enough room? And if you have a crowded, narrow, underdeveloped malocclusion, you don't have enough room for your tongue. And if you don't have enough room for your tongue, you're bound to have a sleep disorder breathing issue. She also has the TMD issue. So we have kind of the comorbidities showing to light here: overweight and TMD, and also, you know, the malocclusion and the sleep disorder breathing. So her symptoms, we learned, the ear pain radiates up to her head. She has pain when chewing for as long as she could remember. She doesn't ever remember chewing comfortably. So right down to childhood, she always struggled to chew comfortably. Jaw clicking and popping, ringing in the ears, fatigue. You know, these are all common symptoms of the patient who struggles with some TMD issues. Then we get in close. So now we can see, okay, so this is not only a crowded malocclusion, but it's collapsed. You know, crowding comes with narrow, collapsed. All the teeth are leaning in. So everybody's leaning towards the tongue. So if you take a look at this photo, at some point when we get through treatment, we'll have the side by side to compare. But right now we start thinking about what kind of space does the tongue have there? Because when this patient is trying to be the obligate nasal breather that every human being is, we are obligate nasal breathers. When we're trying to be a nasal breather and we have our mouth closed, that tongue has a very limited amount of space that it can be pulled forward and parked into. And that's going to deliver a tongue that has posterior displacement. So if you have this type of arrangement, it's very difficult to have your mouth be closed while you're breathing through your nose. It's going to build an amount of nasal airflow resistance, which is going to then produce, you know, some level of sleep disorder breathing. And in her case, we're going to learn we already have a mild OSA diagnosis. So we've got every bit of that crowded malocclusion. That crowded malocclusion comes with a narrow arch, a high vault, of course, a lack of space for, you know, the tongue to really live in. And where we're headed here is someone who has a long list of symptoms and over a very long period of time. What you notice on tooth number 7 is a little composite. They placed a little composite there because it's further back. The actual tooth is a little more lingual, and a little composite was put on 7 by someone just to make it, you know, a little more forward looking. So now we could see that a basically full malocclusion front to back. None of her teeth connect appropriately. So if we've got this level of malocclusion, now we have the list of TMD symptoms, because basically the lower jaw can only land where the upper jaw gives it permission to land. So depending upon where the upper teeth are, which in her case is narrow and collapsed in, the lower jaw has to land according to this. So we like to refer to the upper jaw as the criminal and the lower jaw as the victim. And so the lower can only go where the upper, you know, will allow it, which means it's kind of trapped. So usually we start recognizing that more we're paying attention to the TMD category, we start thinking about, hey, a lot of these patients are narrow. A lot of them have crowding. A lot of them have a deep bite to start. But what they really have is a trapped mandible. And so with the lack of development in the upper arch, that mandible is completely trapped. It can only land where the upper is letting it, which is in a restricted position. So developing the upper arch is going to be our solution. We're going to look to open that up so that the lower can kind of migrate forward a little bit. So we learn about this patient through a collaborative care where at our TMD specialist, and Dr. Gelb had met this patient, and I had the opportunity to do the orthopedics and orthodontics. The idea was this patient began with Dr. Gelb having anterior disc displacement, reduction, left TMJ, myofascial pain. There was a sleep study involved. The patient had mild obstructive sleep apnea. She has this deep bite, that crowded malocclusion, which is just awful, but her mandible is trapped back. So where she began with very severe symptoms, he was able to take her through, you know, a TMD protocol that reduced her to a more mild symptom level. But then we had the opportunity to collaborate and discuss, well, what are the orthodontic options? Can we change the teeth, the bite, the muscles, the position of really everything to deliver a result that could be a big improvement for her? So naturally, there's an orthodontic component coming. And in this patient's case, like most others, we're looking for an expansive technique. So if we're looking for wider and forward, we tend to want to be in the, you know, treat the cause category, whereas treating the symptoms, you know, would deliver one pathway. And so in the treat the symptom category, we can have the TMD splints. We can use, you know, day and night. We can work our way to night only sometimes. You know, this is a patient who, prior to my meeting them, they did have an opportunity to try a dental sleep appliance, but the mandibular advancement device that she was trying was too harsh and the TMD symptoms were then exacerbated. So she wasn't able to wear that appliance. So basically her mild OSA led to that mandibular advancement device, which was a little too much of a strain and she couldn't wear it comfortably with her TMD symptoms. But this is someone who's been to an ENT, has had physical therapy, has tried different medications, and most of them, are to juggle the symptoms. How are you feeling? Is it inflammatory? Is it painful? What are we doing to manage the symptoms that the TMD delivers? Whereas a lot of that could be done to reduce from a severe to a mild category. Then the next direction is, well, what can we do to maybe work on the cause, which is underdevelopment? And if we're thinking about the cause being underdevelopment, we're looking for a wider and forward approach. So it just so happens that clear aligners are very capable at delivering width and forward. So the fancy words are expand and procline, but when you're thinking about wider and forward, if you're developing the upper wider and forward, the mandible is going to follow it. So you could make a difference in how all of the musculature, condyle, and disc, coordinate throughout treatment. So we're trying to be in the treat the cause category so that the patient doesn't go back to night guards and splints and other therapies that are palliative for her TMD symptoms. We're trying to get to the point where the patient just needs to wear a little clear retainer at night to maintain what we've done and live in an asymptomatic condition for basically the rest of her life.
So in a patient like this, she didn't have a posterior crossbite. If someone had a posterior crossbite, would you start with an expansion appliance first and then go to
Yes. Yeah. So we have a couple of categories where the patient would be better off with an upper removable adult expansion appliance. And so one of those categories is posterior crossbite. And if it's a single premolar, one or two premolars, you can probably do it with clear aligners alone. But if a patient comes in and has one or more molars in crossbite, which is fairly common in underdeveloped maxillas, then you're really looking for a removable adult expansion appliance. So posterior crossbite, absolutely, that would be indicated first. We would graduate to clear aligners after correcting with the posterior crossbite. Yeah.
Perfect. And our friend Kevin Ollendorf, I know he co-sponsored this, so I know you used Kevin's appliances, like a 2-screw appliance for. In this case,
oh yes, yeah. Kevin makes a beautiful appliance. I've been using those for maybe a decade now. That's a wonderful laboratory, and he makes all of my removable expansion appliances for the teens and adults.
So this was such an interesting concept. When I first heard you lecture about this, is everyone seems to think it's the mandible is the problem. But go ahead and tell us a little bit about the maxilla's role.
Yeah, so like I introduced it a little bit before, the maxilla is the criminal. And so, the maxilla is so-called the fixed arch, the mandible is the movable one. Well, the mandible can only land where the maxilla allows it. And so when you have a narrow maxillary arch and or retracted maxillary anterior teeth, your lower is going to be a victim and it's going to land behind it. When you think about class 1, 2, 3, every class 1 and 2, the mandible lands behind the maxilla. Only the class 3 patient, the mandible escapes or lands in front of the maxilla. So in the overwhelming majority of our malocclusions, class 1 and 2, which by whatever percentage you're using, if the class 3 population is 3% or 5% or 7%, whatever it is, we're well over 90% of our malocclusions have a maxilla that is underdeveloped, and our class 1 and 2 patients have a trapped mandible. So if you've got a trapped mandible, it's the upper jaw that is the criminal. It gives permission to where the lower jaw can go. So we've got a victim. The victim is the mandible. And the mandible is going to close where the upper jaw allows it. Now, the narrow maxilla traps a mandible back. The maxilla that didn't grow forward or has reclined upper anterior teeth is going to trap a mandible backwards. So we're really looking for maxillary development to allow the lower to kind of close where it belongs. Now you're going to be able to deliver the musculature, the condyle, the disc, everything else can start falling in place if you can get the mandible to land where it belongs.
Great. So let's take a look at her before.
Oh yeah, that's what we're talking about, treating malocclusion. So now this case, this nice young lady used clear aligners alone. And so we're looking at a patient who used clear aligners alone to work our way from the left side of the screen to the right side of the screen. Now, the entirety of the treatment is wider and forward. And wider and forward opens up the arch. And when it opens up the arch, it changes the entire view of the vault. And it's really clear to see that the patient now has a lot more room for the tongue. When you have the before and after, then you can have a better perspective. When we only look at the before, maybe it doesn't look so bad, but when you look at where you belong, now you can see, oh, look at that. It's pretty much, much wider. But now, not only do you have the proper arch form, the teeth have a beautiful dome shape right around, but you've got an appropriate arch width. With a proper arch form and a proper arch width, all of a sudden you have a really nice position for the lower to follow and kind of land into this. Now, the tongue's home is the palate. So while the tongue is kind of attached in the mandible and works its way up around the lower jaw a lot, the tongue really belongs in the upper arch. So when we look at our research in the sleep disorder breathing and OSA category, all of it comes back to the underdevelopment of the upper jaw. So we see a lot of relationships in the research of the anatomy being narrow and vaulted. And so the anatomy, the combination is narrow arch, vaulted palate, elongated soft palate. Those are all part of the underdevelopment of the maxilla. Now, if we start shaping this appropriately and giving the tongue more room, it'll take it. It wants to have that space. This, of course, is going to show in the lower as well, because the lower was completely lingually inclined. So the lower teeth are all leaning in. Meanwhile, we need them out. So they're going to follow the upper teeth out. All of this wider and forward opens up a bigger chamber. So every millimeter that we can open up delivers an exponential increase in the volume of space that the tongue has. So we get to a point where all of a sudden we have this beautiful set of teeth that is appropriate, inclination all the way back. We have a broad, wide arch developed. We have teeth that now receive vertical load. If we think about the left side of the screen, that's a lot of horizontal and occlusal trauma type forces on those teeth. And we know what happens with horizontal and or occlusal trauma type loading. We're going to see deterioration like she has, recession, abfraction, all of the different things with tooth chipping and wear and tear and discomfort, sensitivity. But if we take the opportunity to upright all those teeth, develop the arch width, all of a sudden we have an occlusion where all of the entire posterior segment has vertical load. We get a direct cuspin fossa or cusp on marginal ridge connection. And the teeth now, when they're being used, can deliver appropriate vertical, protective load to each other. And it can slow down the process of all of the things that were part of the occlusal trauma. But the real big picture is how much room does the tongue have? If you're the tongue looking forward into the chamber, on the left side of the screen, you're looking into this narrow corridor that is a terrible space. And then you're looking at that and you're going, well, I can't fit in there. What am I going to do? I don't fit in that. So I'm going to hang out back here. So the left side of the screen is a good view of what posteriorly displaced tongue will be. The right side of the screen, which is just the after picture, after moving all the teeth out, now the tongue has a view into this wide open chamber that is more than enough room, and the tongue will take its position forward. If the tongue can be high and forward, it can't be posteriorly displaced. So all you need to do is open up that chamber, give the tongue the opportunity to be up in the roof of the mouth, and it'll be there. And so then you expect to have not only a good occlusion, we expect to have a lack of or a disappearance of the TMD symptoms as well, which is where we're headed. So the patient develops a more broad smile. It starts to fill in the whole corridor. And next thing you know, you have someone who is visibly different in the photographs. And one of the biggest changes that we would see would be the TMD list would go away. The patient would become completely asymptomatic across all TMD categories. Now, the next level we would notice right away is weight loss. And most interestingly, the patients who struggle with the overweight category, as the tongue has more room and can come forward, when you start to lose the sympathetic drive that comes from that airway resistance, from that tongue being posteriorly displaced, all of a sudden the opportunity is that if you're breathing better, you don't enter sympathetic drive at night. Now, parasympathetic is rest and digest. Sympathetic is fight or flight. So the patient who's not breathing well is going to have a fight or flight issue. Fight or flight is an inflammatory issue, but fight or flight also does affect the digestive system and right down the line. It takes energy to run sympathetic drive and fight or flight. And so what happens is a cascade of events that cause a patient to do two things. One would be if you're breathing poorly, you're going to need more energy to run sympathetic drive all night long. So you start to increase your intake all day long. And then number two, your body won't release it. And so the two culprits for that are called ghrelin and leptin. So it's fascinating to learn about ghrelin and leptin, because what used to be a long time ago, before I learned, what this all meant, I had an understanding, or at least I thought I had an understanding of weight gain causing worse breathing. And in a short answer, weight gain can make your breathing worse, but it's the poor breathing that gave you the weight gain. So when you're putting, the items in order, you don't start out overweight. What you do is you start out having your underdevelopment, which leads to the breathing disorder. Now, the breathing disorder drives the sympathetic nervous system, which affects ghrelin and leptin. And the way they affect ghrelin and leptin is this. Ghrelin is the short-term actor. What ghrelin does is it tells you you're hungry, you should eat, and then it tells you you're full, stop eating. Leptin is the enzyme that then regulates your body weight over time. So ghrelin is for short-term. I'm hungry, I'm going to eat. Oh, I'm full, I'm going to stop. Ghrelin regulates that. Leptin is the one that over time kind of balances your weight out. Now, if you're in sympathetic drive every night from poor breathing, ghrelin all of a sudden has you eating more. It's going to tell you you're hungry, start eating again, but it won't tell you to stop because it wants to have the storage of the fuel to run and burn all night. So now ghrelin makes you intake more, and then leptin sits on the sideline. It won't release anything. So now you're a storage facility. You're basically going to keep everything. So you start to gain the weight. The bad breathing leads to the weight gain. The weight gain can make your breathing worse. The moment you give the tongue more room, and if the tongue was a major part of your problem, if the tongue has more room and you're breathing better, next thing you know, you will lose the weight. So patients like this experience weight loss, and significant, 30 to 40 pounds, without a change in diet or exercise. So with no change in diet or exercise, the patient will lose 30 to 40 pounds over the course of treatment. What you've done afterwards is you've confirmed the tongue was a big part of the problem. One of the opportunities that we had, or I had, with asking Dr. Simmons about the difference between the nose and the mouth, as far as wanting to know how big an impact could I have, well, I learned from him that the tongue is 90% of the problem. And so if the tongue space is 90% of the problem, my efforts to give the tongue more room should be fruitful, and they are, because this is not the rarity, this is the norm. When we give a patient's tongue more room, we expect to see a difference, and across the board, in the breathing, in the sleeping, in the TMD, all of these things should change, provided you've given the tongue enough room. And a significant amount of room is appropriate because the tongue is supposed to have a big chamber to live in. So this changes her life.
Wonderful. So yeah, the results.
Completely asymptomatic. So this is a patient who had, struggled with TMD symptoms most of her life, didn't remember ever eating a meal without discomfort. And we have a patient now after treatment who is completely asymptomatic. She only wears a clear retainer at night. So she has a clear retainer to wear to bed every night, and no longer having splints or night guards, and is able to, wear the retainer every night to maintain the position of the teeth and the alignment of the occlusion now. Medication free. So yeah, if you don't have an inflammatory process and you don't have discomfort, you don't have to keep taking medication. So you can lose your medication list. As far as the sleep goes, a patient like that who starts out with mild obstructive sleep apnea can repeat a sleep study and show up without OSA. So the mild category, there's a lot of success getting people from mild OSA out of it by developing tongue space. In the moderate to severe OSA category, it's not as much, but you can make an improvement, and then you have to address the other items. And there are usually more than one item involved with patients. But the good news is that thanks to learning from Dr. Simmons that the tongue space is 90% of the problem, we have a big opportunity to make a difference across the OSA category, not just the sleep disorder breathing category.
Wow. Well, it's a wonderful case. And the weight loss, who knew, right? So many people don't know that could be the best hidden secret.
Yeah, well, the funny thing is, early on, we used to joke about it because the patients would say, I'm going to have this thing in my mouth, I don't want to take it out, I'm going to stop snacking. And there are patients who stop snacking, and they'll tell you, oh, this thing prevents me from snacking, I don't want to take it out. We hear that a lot, but there are a significant number of patients who come back and say, this doesn't stop me, I'm still snacking, I'm still having this stuff, I thought this was going to be a diet for me, I wouldn't want to take it out. But we start asking the patients to keep track of, okay, well, who's doing what? Who's changing what? And the patients who do not alter their diet and then do not alter their physical routine, but experience weight loss, here you go. You're leading down the road of better breathing. And better breathing we're having a direct impact on the tongue space. So the tongue space is kind of critical, and the tongue space comes from, are we collapsed and we're compromised in our tongue space, or are we opened up with a wider and forward technique to deliver the tongue space again?
And most importantly, you have so many patients who you've improved their life, you've changed their life, and it really makes you happy to go to work the next day.
Oh yeah, unbelievable. And these come in weekly. And so I can give you in just a few seconds, the most recent gentleman came in last week. He began with an AHI of 37. He's now at 7. And so that's a nice case where one day it'll be one of these meetings where we can throw him on the screen and say, here's someone who has your 37 AHI down to 7 in just the course of 15 months of a clear aligner technique to open up that tongue space for him. And so again, without a change in diet, without a change in exercise, he has weight loss, his AHI drops down, he gets himself out of the OSA category. And that's a weekly occurrence. When you start doing this more and more and more, you get to enjoy those, kind of results.
And I'm sure you get to see their family and friends as well, right?
Yeah, they send a lot of people to see you because they're very happy with what went on. Yeah.
Wonderful. Okay, so we're going to get to the questions. Thank you for sharing that case. It's always so inspiring to see exactly what, in this case, clear aligners can do, but also with the help of removable expanders, you have a lot of options to help your patients become healthier. One of our questions, which I always love, is where can we get more training? And here we are. That's why we developed our Airway Health Solutions mini residency. And I'm excited because we're starting off the new year with a sold out course in January. So reach out to me. There is a waiting list, and sometimes things come up if you're really gung-ho about joining us. But what this mini residency does, it's a technique course, and you can learn Dr. Miraglia's tried and true techniques that he's learned over the years, over what, 18 years now of interceptive ortho, would you say?
Yes. So yeah, from treating children age 3 all the way up through the adults, this is going to be my 18th year doing that.
Wonderful. And we certainly don't have enough airway dentists. Dr. Scott Siegel is on the show, and he had said there's really a demand for it. I had 5 patients today. If there's anyone out there in Southern California, they want to know if there's an Airway Health Solutions dentist they can go to in Southern California. I get this in Miami. So really, it's such an opportunity for dentists to really jump on and become airway dentists and treat past the teeth and the foundation. So we hope you look more into our course. I'm happy to answer any questions. We do have a webinar on our website to kind of give you an overview of how we got where we are, and more importantly, what we can do to prevent and even fix it in children and adults. Anything you want to add to that, Dr. Miraglia?
Oh, it's a great course, and I'm really proud of it. I've spent a lot of time, working my way through the education in different directions to kind of put together the techniques. And I'm really happy to teach the how, to do it, because more and more dentists need to be involved treating children and adults in the growth and development category. And these 2 days can give you the opportunity to treat the patients, not just knowing that it exists, but actually get involved and help the jaws to grow wider and forward, to take away the sleep disorder breathing conditions and deliver a really happy, healthy human being at any age.
Yeah, and the good news is that you can take either the 1 day, the pediatrics, or just the adults, but we do recommend taking both days, and it's all online. So it makes it even easier for you. So please consider learning more about that and reaching out to me. We do have some other conversations coming up. Dr. Steve Carstensen is coming in on the 27th. So we changed that from the 20th. There's a prior engagement on the 20th in the nation. So we're going to move it to the 27th. And as we know, Dr. Gerald Simmons is joining us on the 10th, and we'll have Dr. Scott Siegel come again March to talk about infants and pediatrics, tethered oral tissues. Dr. Jerry Curatola is going to join us, as well as other dentists and doctors in the future. So we're excited about that. We're also excited that we become part of the Health Flash Circle. And if some of you may have seen my last conversation, I actually had the founder, Dr. James Thomas, on our conversation series, and we did a whole webinar on it. So I will send some follow-up information, but Dr. Miraglia is now a structuralist and part of the Health Flash Circle. And really what it does is it simplifies collaborative care and it drives airway searching patients to your practice. So it's a win-win. I won't spend too much time on this since we did a whole webinar on it, but I know Dr. Miraglia is excited to be part of the Health Latch Circle, and we'll send out some more information on that.
Yeah, that's a really nice thing. I'm really excited about that.
It's timely too, right? We know
Yep.
It's funny because it's part of our solution, really. We try to help as much as we can with collaborative care, but this is a whole platform that does it for you. So it's really affordable as well. So we do have a code. Let me go back to that. We do offer a 20% discount. The code is AHS20. So that's on behalf of Airway Health Solutions and the Health Latch Circle. So our friend Dr. Liao is going to pop on any moment. I don't know if he's on now, but I know we had him on in early December announcing his book launch, and that will be available January 15th. I will also email you some special pricing courtesy of Airway Health Solutions. And here he is. I knew it. Timing's everything. Okay. Let me just take you.
Hello, Dr. Liao.
Let me ask you.
Hi.
There we go.
How are you?
Yeah, welcome.
I'm great. I'm great.
Terrific. Can you just tell us a little bit? We're so excited that your book is going to become available on the 15th. I know we had such a fun time the last time you were on our program reviewing how valuable this book is to your patients and timely as well. Basically, I said it's good for any human being on the planet. So why don't you tell us a little bit about your book and anything special you want to add?
Thank you. Yes. So the special run through the 15th. We have a promotional price. So it's available today, tonight, tomorrow, and through Friday. And so the big difference is this. You know, the mouth is to humans what roots are to plants. Every one of us, when we were born, could not hold up our heads, but we could suck for dear life. And it is through repeated cycles of sleeping and breathing that we grow, all right? So if this part is off, the rest of the body is off, because this is literally our foundation. So the mouth is involved in the respiratory system as well as the digestive tract, and they're actually interrelated, as Ben so brilliantly explained earlier. And I was particularly impressed by those 5 circles you had at the beginning about Tmd and OSA and obesity and malocclusion. And so what this License to Thrive is about is that it's a mouth owner's GPS. If you're a mouth owner, what do you need to do to get to thrive your health, right? So you need both the structure, which is the wide palate to free up the mandibular entrapment, and then you need to eat healthy. So this is the first book that basically linked oral appliance therapy to a bone building diet. You know, how do we grow a wider arch, right? You can't just tip the teeth, right? So you need to make sure that patients have bone building ingredients. And so that's why I integrated the digestive tract with the respiratory tract. And that's why you see the blue and the green in the book cover icon there. So the symptoms, the variety of symptoms that comes from a structurally impaired mouth and the poor standard American diets health outcome, I call it impaired mouth syndrome. So impaired mouth syndrome is defined as oral contributions to any symptoms. So that's what we treat. We don't treat sleep apnea, at least not in my opinion. I don't think that we should, as dentists, be treating sleep apnea. That should be a sleep doctor's job or a neurologist's job. But I do think that we are indispensable to the sleep issue by addressing the oral contributions to sleep and obesity and sleep apnea and also COVID risk. So you know, this COVID pandemic, everybody's talking about social distancing, washing hands, and wearing masks. Nobody's empowering the patient on how to eat healthy, how to widen the airway. You know, if you started oral appliance therapy back in March, at the start of the lockdown, you could be free of your OSA by now. All right. So, and reduce your COVID severity risk substantially. And I have several patients who have accomplished just that. So my kudos to Lauren and Ben for putting together this program. This is just my little way of contributing to the patient's understanding of what Airway Health Solutions does, what Airway Mouth Doctors do. All right, so there is no end to this kind of cases. You know, it was fun for me to hear how night guards patients are built in for clear tray treatment. Well, I'm telling you, anyone in your practice who's got crowded lower anterior teeth, they have impaired mouth syndrome. It's just that nobody's ever connected the dots for them. Right. And we do that in this book. Hopefully this will drive up your patient's demand and recognition for what you all do. So recommend this to your patients, have them read it, and don't be surprised when they come knocking on your door and say, oh my God, what do I do now?
Absolutely. I know the 6-foot tiger, 3-foot cage certainly did that effectively. And since I had the opportunity, Dr. Miraglia and I, to read this as a preview, so thank you for that. This really is the full picture. So I'm excited to share this to my patients. I know Dr. Miraglia is as well.
Yeah, I'm looking forward to sharing that with everybody I know. And then if you're just seeing this for the first time and you're not aware, Dr. Liao's other book, Lauren just mentioned it, 6-foot tiger, 3-foot cage. That's a really good book. And everybody in the dental community should have that book and get through that one and this one. And then it gives you the bigger picture. You need all the pieces of the puzzle. And then you can make a nice puzzle when you have more pieces.
Right. And so if I may just say one thing, this book comes in 3 different editions. Digital edition, which is in full color, a black and white print edition, because some people want basically a physical copy in their hand. And then there's a color edition. I recommend that all the healthcare professionals get at least one color print edition for themselves. And then for their patients, during the promotion period, for under $19, you can get both the black and white print physical copy to hold in your hands and the color edition to have all the color slides in the digital edition.
So you sent me a very informative email that I'll pass along to all the listeners, all the registrants, so they'll have that and they can choose accordingly.
Yes.
Well, Dr. Liao, thank you for all your contributions. Thank you for your work. Thank you for sharing, and thanks for coming on tonight. We can't wait to read License to
It's a delight, and keep up the great work. It's I see you guys as pals and fellow leaders in this journey, trying to educate dentists so that they're not just tooth carpenters. There's nothing wrong with being a restorative general family dentist, but the earth is no longer flat, and we should keep Airway in the center or forefront of our awareness. And certainly a mouth owner needs to know that we Airway-oriented dentists really are the most pivotal doctor they'll ever need. Because between digestion and airway, everything else has to take a back seat. All right, thank you.
Amen.
Appreciate this.
Okay,
Keep
Dr.
up the
We'll
great
see
work.
you soon. Thank you again.
Thank you. Take care.
Ciao.
Bye. If you also want to get more information, thanks, Dr. Liao. Follow us on Facebook, Instagram, YouTube. I just posted a new blog, and I'm posting another new blog tomorrow on my journey and my visit with Dr. Miraglia. So come take a look at that. It's also very patient friendly. I do that on purpose so you can share that as an educational resource. Here's our contact information. I want to thank Kevin Ohlendorf and Ohlendorf Appliance Labs for partnering with us so we can offer these conversations monthly now. So that's exciting. Thank you, Kevin. And there's his contact. Okay, so we have some questions. I'm going to go ahead and stop sharing my screen so we can have the full screen. And a lot of these were answered actually during your case review, so I won't be redundant. But
Okay.
are all grinding cases related to airway sleep apnea issues? I know all is a tough word, but.
Yeah, all is a tough word. Oh, it's hard to say all, and it's probably not appropriate to just say 100%. But, you know, having spent a fair amount of time talking to Dr. Simmons, you start to feel like, oh boy, look at this. If that patient's lower jaw is moving, clenching and grinding, you know, his quote says most, which is at least fair, but I think we're going to have fun on February 10th talking to Dr. Simmons for an hour about the movement of the lower jaw and how the predominance is just related to the breathing issues.
And do you recommend a TENS unit for fabricating night guards and splints?
So I don't make night guards and splints, and the patient who I would think about using a night guard for, I automatically start to teach them about the bite, the malocclusion, the underdevelopment. I'm guiding them towards orthopedics and orthodontics. And so I prefer not to make a night guard. And so I don't use the TENS unit then.
Okay. One of the dentists who's actually experiencing TMD himself asks, can you expand someone having TMD symptoms, or do you need to wait until it calms down? And then he just goes on, let me continue. It seems like expanding may solve the problem, but I've heard some gurus say not to do orthodontics until the TMD issue is solved. I personally have TMD and it isn't going to calm down on its own.
Right. And so, yeah, you know, it depends on the technique being used. And so when we use the word orthodontic, that means straight teeth, but it doesn't indicate what are you doing, because wider and forward is what you're looking for, but there is such a thing as retractive orthodontics or narrow orthodontics, where if you're doing something that's going narrow and back, you have a better chance of getting TMD symptoms versus relieving them. So the word necessarily isn't the answer. It's what direction are you going? So yes, we do take patients with mild to moderate symptoms immediately into growth and development orthopedics and orthodontics, where what I mean by that is wider and forward. So if the technique is wider and forward, we find that we have symptomatic relief within days to weeks. And then by the culmination of our treatment, there are no symptoms left. We're supposed to be completely asymptomatic. The patients in the severe category, usually that comes along with disc displacement and or locking and things that are really trapped in the wrong place and excessive levels of inflammation. That's where I would guide a patient to the likes of a Dr. Gelb, where he can help me with that patient. And with the collaboration, he's going to recapture the disc. He's going to reduce the inflammation. He's going to get that patient stabilized. And by stabilized, I mean comfortable enough and in a position where maybe the symptoms are mild or non-existent, but he's got them in a place where I can jump in and do my wider and forward orthopedics and orthodontics so that the patient never lands back where they were. And, you know, that's the opportunity in the severe category. Yeah, we want to bring that patient down, and it's recapture disc, reduce inflammation, and get yourself to a mild to moderate level. But mild to moderate, as long as you're going wider and forward, you should have almost instant results and be pretty comfortable to go through treatment. But
what is
the other way is trouble.
What is the percentage of successful cases to improve airway with ortho?
Again, what kind of ortho are we doing? Because if we're extract and retract, well, that's the wrong direction. We're taking away tongue space. If your orthodontic technique is wider and forward, you're giving the tongue more room and you're creating space behind the tongue for the air to flow better. So if your technique is wider and forward, then every single millimeter that you give the tongue room for or open that space is an improvement. So if you're practicing a wider and forward technique, you should have a 100% rate of improving someone's airway symptom list or airway compromise or airway issue. And so you have an opportunity to make an improvement only if you're going wider and forward. If you're going to be going narrow and back, it would be the opposite of that. It would be 100% rate of making it worse. So whatever room the air has to flow, if you're going narrow and back, you're taking away tongue space and driving things backwards. Now we're going to have 100% rate of making it worse.
How would you treat TMD in a growing child?
Growth and development. And so, yeah, and those are the easiest ones to do. Now, the rate in kids today is somewhere between 6 and 16%, depending upon what you're reading. But the idea is we meet these kids who are 4, 6, 8, 10, 12. They already have the TMD symptoms, and it's because of the maxillary underdevelopment. So the immediate answer is they need expansion, but both jaws. So those kids are in need of 8 to 12 to 16 to 20 millimeters of expansion, depending upon the diagnostics. And when both jaws are delivered wider and forward, the TMD symptoms, like every other patient, go away within days. And so with kids, it's much quicker. So smaller percentage of TMD, but larger percentage of sleeping and breathing issues. The children who are underdeveloped come in with a lot of symptoms. TMD is a smaller one, but the same direction of wider and forward with expansion appliances delivers an asymptomatic child in very short order.
What is the best appliance during myo, during expansion, fixed or removable? Please give examples of each that you suggest.
Yeah, I have preferences. And so, the idea behind appliances mostly comes down to preferences for age groups. So when we're working with children, I prefer fixed appliances, and I only used fixed expanders for kids, but both a top and a bottom. When we're working with adults, it's only removable. And so removable expansion appliances apply to adult treatment. Fixed expansion appliances apply to children. I'm a big fan of the upper super screw expander. It's a 2-band expander. It has, a super screw across the middle, which is a hexagonal wheel that has a wrench. So it's very easy for the parents to turn. I'm a big fan of anterior finger spring arms to be able to procline the anterior teeth. I love a lower Schwartz. A lower Schwartz fixed expander is a beautiful appliance. In the lower arch, it's excellent for uprighting, which all of those teeth are lingually inclined anyway. And if the upper arch needs anywhere from 8 to 20 millimeters of development, you're going to need some movement in the lower to catch up with that. Ultimately, if you have a technique that addresses both arches and delivers enough expansion, you keep your wisdom teeth. And so that's where we're headed, because the kids we get early keep their wisdom teeth, and keep meaning erupt. So you're looking for 32 teeth as an end result, not 28. 28 doesn't do it. If you're a human being with 28 teeth, you don't have a big enough perimeter for your tongue to fit in. A human being that has a fully developed set of jaws has 32 teeth in a position that the tongue can park itself in. Now you've got a good breather on your hands. So if you're looking for best breathing, best sleeping, best health, you want fully developed jaws, which means you have 32 teeth erupted into position. The expansion that's done early on children should be setting the tone for their wisdom teeth erupt. And so that's the pattern that we're on, where most of the kids that we treat keep their wisdom teeth and they erupt right into place.
Wonderful. Please clarify if a traditional night guard makes TMD worse.
Traditional night guard doesn't necessarily make TMD worse. I don't believe I said that, but the idea is a traditional night guard, while it's being worn with either TMD or clenching and bruxing and grinding, you would still have the wear and tear on the night guard. In other words, the night guard doesn't cure a clench, a grind, a brux, a TMD. What you get is basically a release of where the lower jaw might be resting. And you can use a night guard to protect against clenching and bruxing so that enamel's not being worn. But when you have a night guard in place, it's going to take the beating. So it's common to give someone a night guard and then inspect it 6 months or a year later and find marks all over it because the lower jaw is still moving. As far as TMD, a night guard or a splint or an orthotic or whatever we might be calling it, what it's doing is it's separating that malocclusion. Basically what a splint or a TMD type of appliance, it takes the criminal away from the victim. It basically gets between the two. So now you've got your mediator. It gets the criminal out of the way so the mandible doesn't have to be locked into where the maxilla is making it go. You're giving it a position where you now have the muscles, the joint, the condyle, the disc. Everything is right except for, that's not the bite. That's an appliance in place. Now the patient has to take that out to eat and function. So we still have the repeated use in the wrong position, which means we're in the treat the symptom category. Then the opportunity is, why don't we develop the upper jaw, never need a split. That's a really nice, opportunity to have. And so you just have more tools in your toolbox to help your patients going forward.
And what is the relationship between premolar extraction cases and TMD?
Well, I'm not a research facility, but I'm also in my 27th year. And so this is 27 years. And I think, the more GPs that start paying attention to their patients, because they do have to follow them forever, the GP community has to see these patients forever. Whereas an orthodontic community might treat the patient and then release them on some level. There isn't long-term follow-up there. But a GP practice, if they were paying close attention, they might recognize that in the 4x extraction category, you probably have a longer list of symptoms that are related to having less room for the tongue, having a more retruded or trapped mandible. And so the more you start paying attention to your OSA patients and or your TMD patients, the more you might recognize, hey, this is a 1, 2, 3, or 4 bicuspid extraction orthodontics case. And the idea is patients who have had extract and retract have less room for the tongue. Patients who've had extract and retract have a mandible that's trapped back. Well, a mandible that's trapped back has a tongue that's trapped back. A mandible that's trapped back has a condyle and disc relationship that's not appropriate. So basically, if you're keeping track over the course of your career, you might recognize that the 4x extraction cases going forward, those patients tend to struggle with the TMD problems, the occlusal problems, the periodontal problems, the endodontic problems, and then your airway problems. And so it's just a matter of following, but I'm not a research facility, so I don't get to say I have research and this is the rate, but I also get to, enjoy feedback from speaking around the country for the last 15 years as well. And I can hear from a lot of different GPs that as they pay more attention to it, they recognize that, yeah, the 4x extraction patients tend to deteriorate more rapidly. Well, a patient with a bad occlusion, a patient with poor breathing, a patient with the rest of that symptom list from breathing to malocclusion to TMD tends to deteriorate faster. So they're basically aging too quickly right at the oral cavity. And so there's a difference between aging appropriately and deteriorating. And 4 bicuspid extraction is a pretty fast way to deteriorate.
Can you simply state, and then we'll wrap it up, what is the relation between TMD and narrow upper arch and narrow arches?
Oh, sure. Well, the simple answer is that the more narrow the upper arch is, the more trapped a lower jaw becomes. So the upper jaw, the lack of development in the upper jaw produces a mandible that's trapped back. So again, we think about class 1, 2, 3. There's very little class 3. The majority of class 1s and 2s are underdeveloped. So if you're an underdeveloped class 1 or 2, you have a maxilla that is not wide or forward enough. Your mandible then is no longer in a position where it should be forward in position, meaning in the right place for your musculature, your disc, your condyle to all be lined up. So if we're going to have, balance and harmony and everybody working together, we need the upper jaw to be where it belongs so the lower can land appropriately. So yeah, the underdeveloped upper jaw is your pathway to having TMD symptoms.
And the very last question, I promise, is what is the youngest and oldest person you have expanded?
3 years old is the youngest, and the oldest patient, 86.
God bless. Okay. Well, that's a wrap. Thank you so much for your time and your expertise. This was really informative and I think eye-opening in many, many forms that so many doctors and hygienists are just used to going right to the night guard as the treatment. And there's so many other options to really focus on growth and development. And you displayed that so beautifully with your case. So thank you so much as usual. We appreciate your time. Thank you everyone for joining us. We will see you on the 27th with Dr. Steve Carstensen. Until then, have a great couple of weeks and I'll send out the follow-up information. Good night, everybody.
Thank you very much. Good night, everybody.
Good night.